All right, I think we'll get underway. We have several folks, and I know some folks always have the pleasure of encountering the joys of commuting in and around the district when it comes to Metro and our roadways. So, but we are pleased to have everyone who's joined us here for the public release of a new report from the Institute of Medicine on the topic of countering the problem of falsified and substandard drugs. This is a report from the Institute of Medicine's Board on Global Health. We will have a 1.5-hour briefing to discuss the report. We'll have basically an introduction and overview of the study, and then we will have an overview of the report's key conclusions and recommendations, and follow that with a Q&A period. We ask when you have questions to come to one of the floor microphones you'll see on either side of the room so we can make sure everybody can hear. The report is available now online with related materials. A simple URL to find everything about this study is www.iom.edu/fake drugs. And also, the Institute of Medicine is tweeting about this event today. If you'd like to join in that Twitter conversation, please use the hashtag #FakeDrugs to share your comments, questions, observations. I would like to clarify for the record one detail. Some of our materials referred to the contextual case of the fake versions of Avastin that have turned up. That was one of the examples recently in the United States. We do want to clarify that we do know that these fake versions are here. We don't have official data documentation on numbers of patients who received or were harmed by those fake versions, but they are of concern. With that, I'm going to welcome to the podium Dr. Patrick Kelly, who is Director of the Board on Global Health. He will give an introduction of the study and then introduce the members of the panel who are with us today.
Thank you, Christine, and good morning, everyone. Welcome to the Institute of Medicine at the National Academy of Sciences. On behalf of our president, I'm very happy to welcome you here. If he was not out of the country, I'm sure he would want to be here in person. But on his behalf and on behalf of the IOM Council, we want to thank you and also thank the Food and Drug Administration for offering us the opportunity to study what is truly a growing and global problem. It's more than an international problem. It's a problem that affects all of us because our borders are porous. The problem of substandard and falsified drugs affects Americans, affects people in other parts of the developed and the developing world. And as we become more globalized, I think it's reasonable to expect that the threat posed by this will only increase. And so we want to get caught up in solving the problem and then get ahead of the problem so that we can ensure that people who need medications get quality medications, have access to them in a timely fashion, and that the associated bad effects of fake drugs are also reduced. As you can read in the report, this is not only about health, but it's also about criminal activity. We had a 12-person committee that we were privileged to be able to appoint to work on this project. The Food and Drug Administration asked us to undertake the project in August of 2011. And they gave us a statement of task that you can read about in the report, but it asked for us to look at trends in the problem to the extent that we could identify trends in what is a very difficult problem in many parts of the world. They asked us to look at risk factors for the problem, the public health consequences of this problem. What are some of the technologies we could bring to bear to solve the problem. And how can we better coordinate with partners in industry and non-governmental organizations and international organizations around the world to build a system that is more effective at dealing with this. We have 6 of the 12 members with us today. You can read their full bios in the report, but I'll just briefly introduce them. At the far end is John Theriot, retired from the Federal Bureau of Investigation. Following that, he spent many years in drug security at Pfizer and followed that with working on similar issues for Apple. To John's left is Hans Hogerzeil, a professor at the University of Groningen. Hans spent decades working on the Essential Drugs Program at the World Health Organization, helping over 40 countries around the world to develop their drug regulatory systems. And to Hans's left is Margaret Namondo Segonda. Margaret hails from Tanzania, where for 7 years she directed Tanzania's Food and Drug Regulatory Authority. And she now works for the New Partnership for Development in Africa. To Margaret's left is Thomas Layloff. Tom is an analytical chemist who worked for the Food and Drug Administration for about 25 years, and now he works for Management Sciences for Health on international drug quality issues. Similarly to Tom's left is Patrick Lucolay, who is with the U.S. Pharmacopoeia and also works globally on drug quality issues and systems. And last but not least, to my immediate right is Professor Larry Gostin. Professor Gostin is a member of the Institute of Medicine. He's a lawyer, and at both Georgetown University and Johns Hopkins University, he directs the Center for Law and Public Health. I'd like to now introduce Professor Gostin and ask him to spend about 10 or 15 minutes telling us about the main messages of the study. And then after that, there'll be time, as Christine mentioned, for questions and answers. Thank you.
Thank you. Thank you, Pat. I want to just begin by reiterating Dr. Kelly's statement that we very much appreciate all the support that we've gotten from the Food and Drug Administration, and we were particularly pleased that the FDA's charge to us was focused purely on public health and global health, and we took that charge very seriously. I also wanted to recognize Jillian Buckley, our fearless leader, staff director on the report, who did the yeoman's work and who knows more about this now than ever she hoped. And Dr. Kelly is just a magnificent illustration of the best and the finest at the Institute of Medicine, and has just been a global leader in global health. And so it's been a rare privilege to serve under him. And then, of course, our distinguished committee, who Dr. Kelly's already introduced you to. We've assembled at the IOM a world-class committee. So we are, I'm going to see if as a lawyer, I never use these things, but here I am in the Hall of Science, so I will. The background to this study is that poor quality medicines are indeed a global problem. There's no country acting on its own can possibly avoid this problem, because we live in a globalized world with porous borders. So from the richest countries like the United States, Canada, and European countries, to low and middle income countries in Africa, Asia, and Latin America. This is a major problem, more so, doubly so, in lower income countries. What we found as a committee is that there was considerable disagreement and variability on how this problem was framed. In particular, there tended to be a conflating of the intellectual property issues and the public health issues. And this broke down cooperation. It meant that different states and different international organizations have different definitions, and it's thwarted our ability to have a commonly understood framing of this particularly important global issue. In order to promote the public's health in the United States and globally, the FDA commissioned this IOM study to better understand the problem and to identify solutions. For those of you who know the Institute of Medicine, committees are demanded to follow their statement of task, and we've tried to do that faithfully. And as I've said, the statement of task focuses principally on the public health and global health implications. With that, in order to forge common definitions, where we don't believe that the precise words we use have to be adopted globally, although that would be helpful. But what we would like is to have too broad an overlapping definition of bad drugs, which would be falsified and substandard. In addition to falsified and substandard drugs, the report also refers to unregistered medicines. These are medicines that may or may not be bad drugs, but often are not, and would be not registered in the country in which it's being used. So our very first recommendation is directly to the World Health Assembly. The World Health Assembly will be meeting in May of this year, and that they should adopt definitions that are consistent with the following principles. Substandard drugs do not meet national specifications because of quality system failures, and falsified products have a false representation of identity or source. Products that are unregistered with the regulatory authority are also unlawful in that country, even though they may not be in another country. The consequences of illegitimate drugs, and please note that the committee is using the term illegitimate or fake drug, not the generic term counterfeit, because we think that counterfeit tends to be too much tied to the TRIPS agreement, the intellectual property agreement, and is too narrow for our purposes. So the consequences of these illegitimate drugs are compromised treatment. They may have no therapeutic active ingredient or a lower amount, that they can be toxic or poison, they can harm patients, and in some cases they can kill. So when patients have trust in the medications they are receiving, but they don't get better, or in fact they get worse, it breaks down trust and it raises costs in hospitals and the whole healthcare system. Very worrying from a national and global perspective is that if a drug has a subtherapeutic dose of the active ingredient, that it can induce drug resistance, and that has a profound effect on the life of the drug, society. We must all bear the costs as we have to develop ever new medications in order to be able to treat that once treatable infections. And these can be everything from staph infections to tuberculosis and other kinds of medications. Consumers lose confidence in the system of medicine, in the health system, and importantly, in the regulatory system, which we have many recommendations to strengthen. And it also funds criminal activities and conveys power to corrupt officials. Many of these fake drugs are the subject of sophisticated criminal networks. The last thing that society wants to do is empower these kinds of networks. We're often asked about the magnitude of the problem. We know it's large. We think it's growing. It disproportionately affects low and middle income countries. We know this from instances of anti-malarial, antibiotic, and anti-tuberculosis drugs in sub-Saharan Africa and Southeast Asia. And we also know that it circulates in countries with weak pharmacovigilance systems and weak regulatory systems. And so you have a race to the bottom in the sense that unscrupulous suppliers will go to places where there's poor surveillance and poor regulation. The causes of substandard drugs are many. They include equipment, staffing, and process costs, which are necessary to meet international good manufacturing processes. These are expensive. It is expensive to make a good quality, safe drug. There's a lack of investment capital and poor infrastructure, which holds back particularly small and medium-sized companies in low and middle income countries. And for want of investment in pharmaceutical manufacturing, the poor pay more for substandard drugs. And so what you have are people who desperately need medicines, where there are great civil society movements for affordable access to medicines, and yet they're getting medicines at a higher price with a lower quality, sometimes harmful to their health and safety. And that's, in our view, a moral tragedy. So recommendation 4.1 of the committee is that the International Finance Corporation of the World Bank and the Overseas Private Investment Corporation in the United States should create separate investment vehicles for pharmaceutical manufacturers who want to upgrade to international standards, which we hope most will. Governments can complement this effort by encouraging partnerships between local and foreign manufacturers. I want to underscore the importance of this. One of the things I was very proud of in the committee is that we thought innovatively about where we would place our recommendations. And here, what we're doing is we're trying to place our faith in investment in the private sector, particularly the private sector in lower income countries and smaller and medium-sized firms, to help them make medications safer, more reliable, and up to standard. And we also want governments around the world to try to create partnerships between local manufacturers and foreign manufacturers so that we can have technical assistance and capacity building. This will go a long way in kind of helping the private sector be able to maintain a good supply chain with good drugs. Falsified drugs really is a crime of opportunity. It's more common, as I've said, in places where where the regulatory oversight is weak or inconsistent, and the committee found very high variability in regulatory capacity around the world. It is difficult to keep momentum for labor-intensive police raids, especially when police are under pressure to investigate violent crimes. And so law enforcement also has a very important role to play. Law enforcement is stretched thin with the illicit drug trade, with gang violence, with civil unrest in some countries. And it's critically important that we have the resources and capacity to take the issue of illegitimate drugs seriously in terms of law enforcement. Here are the causes of both. Regulators in low and middle income countries need training, they need equipment and technology, and guidelines for strategic decisions about what to invest in first. In short, regulators need regulatory capacity. This is something that the FDA has been very interested in for a long time, so is the World Health Organization. The scope of their needs can be overwhelming, and it can lead to inaction. And a strategic plan helps regulators advocate for better support for their ministers and identifies places for donors to contribute. So recommendation 4.4 of the committee is that governments in low and middle income countries should support their regulatory agencies to develop strategic plans for compliance with international manufacturing and quality control standards. And in the least developed countries, international organizations should support their efforts. So there are two really important points of this. One is that we believe that national governments have the primary responsibility to make sure that there is strict regulatory oversight to protect the health and safety of their population and also populations abroad. But secondly, we recognize that some countries, even with the political will, need the technical assistance and the financial assistance to be able to do this. And so we're calling on international organizations to make regulatory capacity part of their funding machinery. Weaknesses in the distribution chain. The FDA realized and the IOM has realized that having a secure supply chain of drugs is critical to ensuring quality. Secondary wholesalers seem to be the weakest point in the U.S. drug distribution chain. State licensing requirements, the committee found, vary very widely. There's a great fragmentation in the United States in terms of our licensing and regulation of secondary wholesalers. And unscrupulous firms seek out states with the minimal oversight. This is the equivalent of the race to the bottom here in the United States, where you have unscrupulous firms that would go to places where the licensing and oversight requirements are the least rigorous. And there's no national database on drug wholesalers. So if a wholesaler fails to meet the requirements or is sanctioned or even is delicensed in one state and simply goes to another state, there's no national system to inform all states and all regulators and all consumers about what high quality, well-accredited wholesalers are. So recommendation 5.1 of the committee is that state licensing boards should only license wholesalers and distributors that meet the high standards of the National Association of Boards of Pharmacy accreditation standards. We are asking the FDA to collaborate with state licensing boards to establish a public database to share information on suspended and revoked wholesale licenses. This is good for consumers, it's good for states, and it's good for the industry. Weaknesses in the distribution chain. As I've mentioned, a strong chain of custody can reduce risks associated with porous supply chains. Just as you might think about, as an analogy in crime, if you have a supply chain of criminal evidence, if the chain of custody is broken, it becomes unreliable. Courts will throw it out. What we want is the same thing for fake drugs so that we actually have authenticity right across the supply chain. Track and trace systems would allow interested parties to know where a drug is at any particular time and see a record of where it has been previously, which is invaluable knowledge. The expense to industry can be contained by imposing one standard without state variations. So, for example, California is going to introduce this, but we need to have something that is cost-effective for industry, and only a national standard can do that because they can't be expected to meet individual state standards because they're very variable. Recommendation 5.2 then is that Congress should authorize and fund the FDA to establish a mandatory track and trace system. This is only something Congress can do. We think it's a grave public health problem here in the United States and worldwide, and we're calling on Congress to consider this. In the interim, because we know that the wheels of Congress grind slowly, in the interim, the FDA should convene a working group of stakeholders, including the International Federation of Pharmaceutical Manufacturers and Associations and the Generic Pharmaceutical Association, to promote a voluntary track and trace for all supply chain actors in accordance with existing guidance. This voluntary system would bring together all stakeholders. You'll note both nationally and internationally, because we think the U.S. Could be a model for the rest of the world. Weaknesses in the distribution chain. In poor countries, there are few quality drug shops outside of cities. Drug sellers don't have proper training. The private sector invests in medicine retail, will invest in medicine retail if there's good business reasons to do so. And governments can use fundraising, accreditation, low-interest loans, and training as tools to improve retail and create an environment where the private sector will thrive. Again, these public-private partnerships, as Dr. Kelly has said in many other contexts, is critical as a global health initiative. So recommendation 5.3 is directed to governments in low and middle income countries. We're suggesting that they should provide an environment conducive to the private sector, establishing quality medicines in retail in underserved areas, such as rural areas, and government incentives should encourage this. And to the same ends, governments, the World Health Organization, and FIP should support national pharmacy councils and education departments to train tiers of pharmaceutical personnel, because a well-trained, highly experienced professional is essential in this area. The committee spent a good deal of time looking at fledgling treaties around the world, such as in Europe, to try to find a solution to this. And we found that existing treaties are not widely adopted, ineffective, and have had a good deal of criticism. And in any case, the political climate today is not conducive to the hard law of an international treaty to solve this problem. But nonetheless, we're absolutely confident that international cooperation is necessary. International cooperation, public-private, international organizations like WHO, national governments, industry, and others need to collaborate. And we believe that the World Health Organization should be a leader in this, and a code of practice, which the World Health Organization has done, in fact, fairly recently with the International Migration of Health Workers, could be a soft norm solution that could give clear, consistent guidance. This is our boldest recommendation, one that reaches out to the world. Recommendation 7.1 then asks the World Health Assembly, again meeting in May of 2013, but in partnership with two key organizations, the United Nations Office on Drugs and Crime, because we believe we need to have a strong law enforcement goal, and we need to get the UN office engaged in this problem, and the World Customs Organization, because this is also a customs issue. And also in consultation with major stakeholders, public, private, civil society, and others, should institute an inclusive, transparent process for developing a code of practice on the global problem of falsified and substandard medicines. The code should include guidelines on surveillance, including making pharmacosurveillance part of public health surveillance systems, high-capacity regulation, thorough and systematic law enforcement, empowering states and the international community to prevent and respond to a very serious public health and global health problem of drug quality. So I wanted to conclude, thank Christine Stenzel for organizing this briefing and being so supportive to all of the committee, our staff director, Jillian Buckley, Pat Kelly, and our marvelous team. And then I will leave it to who's going to, you're going to moderate questions? Okay.
Thank you for that detailed overview of this report, and we certainly hope that everyone will grab a hold of a copy. You can access the PDF, download a free PDF from the National Academy's Press website. Again, a link to the report and other materials is at iom.edu/fake drugs. So we will now open the briefing to questions. And anyone who'd like to ask a question, again, we would ask you to simply go to one of the floor microphones. They're on the either side of the room. Also, we'll ask you to let the panel members know who you are and your affiliation so that, we can all know who's speaking to each other. Thank you.
Hi, I'm Jill Wexler with Pharmaceutical Executive Magazine. Jill Wexler, Pharmaceutical Executive Magazine. I have two questions. One is on the proposal for all wholesalers and distributors to meet NABP standards. I'm wondering how big a deal is this? Are most large wholesalers already meeting those standards and already licensed by state boards, or would this be sort of a major expansion of state licensing board activities and have an impact particularly on the secondary wholesalers and on competition in the industry? And the second question is, how do you envision a voluntary track and trace system would work? There's been a great deal of talk about this. Everybody says we need enforceable national standards for this and international standards ideally. So how would any kind of a voluntary system work? Thank you.
Shall we take the pharmacy board issue first? Yeah, sure.
You came to the chemist. As you, most all of you are aware, the pharmacy boards govern the activities of the practice of pharmacy within their state borders. The NABP has established a very comprehensive set of GXP, good practices. Many states don't adhere to those standards, and we are encouraging them to do that with their secondary wholesalers. There will be an expense to it because if the states put that in, you're basically asking the secondary wholesalers to comply to GXP, which would have the track and trace and things like that built into it, pedigree and things like that, which would make a very secure supply chain. It would increase the cost for the pharmacy boards and their activities and enforcement. And of course, we've seen the problem with the New England Compounding Center, where a wealthy state like Massachusetts was having difficulty enforcing standards on, a pharmacy practice area. So I assume that that would be similar in some of the less well-funded states. It would be difficult, but it could be done, and it should be done.
Yeah, on both of those issues, cost is obviously an issue. The track and trace system that's been recommended is kind of the current evolution of the pedigree system that was included in the PDMA back in 1987. And for various reasons, the requirements of a drug pedigree that were included in the PDMA have not been enforced, partially because a lot of the smaller wholesalers and pharmacies have pushed back on the issues of cost. And the requirement that you maintain a record of every transaction every time the drug changes hands used to require a paper record. Now we're talking about an electronic record. And the discussion consequently has evolved into standards. Who's got the right technology? Is it 2D barcodes? Is it RFID? How do you do the track and trace? And one of the things that the committee would like to see is the establishment of some common standards for doing this. Whether you track drugs at the lot level, whether you track them at the unit level, whether you use RFID. And we recommend that those standards be established by the FDA in consultation with the stakeholders who are involved. And with regard to licensing wholesalers, obviously the big wholesalers like McKesson and the others have no problems with what we're talking about. I think the farther you get down the supply chain, the more resistance you get. And frankly, the spottier some of the players tend to be, and we've seen that in Florida and other states that have had really significant problems with, with bad drugs being introduced into the supply chain through secondary wholesalers. What we're saying is that we should know who handles the medicines that are consumed in this country. There should be a record, and the people who do wholesale these drugs should be accountable for ethical business practices. There should be a record of who they are, and when they're delicensed, or when they have significant problems, I think the FDA and the public have a right to know that. So that's the direction that these recommendations are going.
I would like to add a comment on the track and trace issue, voluntary. All major manufacturers track their inventories and should monitor their sales in the event there is a recall of their product, so they can recall it effectively from their supply chain. So a good manufacturer complying with good distribution practices would have in place a track and trace system so they could run an effective recall of a defective product.
Yes, I'd like to, Patrick Lukule, United States Pharmacopoeia. I'd like to add to Tom's earlier comment on the issue of licensing of wholesalers. I have to state that I was particularly shocked that no database existed wherein wholesalers were being monitored or tracked, particularly those that had been found to have maybe violated some of the NABP rules or were found to be rogue. I mean, in this day and age, electronic IT age, a country like the United States to recognize that at the state level, you could not, one state could not log into the internet and just find out what the credibility of a particular wholesaler is to identify those that have been involved in criminal activities was truly shocking to me. So I think the biggest deal of that recommendation really is with respect to not having a central repository of wholesalers and some of the dubious activities that some may have engaged in.
I would like to add a little bit on the global perspective beyond the United States. And I think I agree with you that this is a long-term view, but that's what we're here for. And we also have to think no country can do this on its own. So you need other countries. So you have to make some sort of reasonable proposition where the United States may go quicker and faster and first, but in the end, others have to follow. And I think the system is simple. There are 3 steps. The first thing is you have to control your borders. So you have to control your importers. You cannot just allow a system that anybody can import medicines. That's the first thing. Then you have to register the people, the institutions that deal with the drugs. So you start licensing your wholesalers and your distributors. That's like in the European Union, where they go now towards that, okay, you register everybody that deals medicines, and then you say, now anybody can only buy some medicine from another registered handler. So then you register the chain. You still don't register the products, so you follow the products, but at least you have, you control what comes in, and you control who deals with the medicines. And in the 3rd stage, you start actually tracking and tracing the individual products. And that, I think, is a reasonable proposition in the medium term. Now, I'd like to say also something about quality comes at a cost. So you see it, global consolidation. I mean, you cannot have a small company producing a good quality drug and then at the same time compete in pricing. It's either bad quality or it's a high price. So you have to consolidate here, but all over the world you see that. And I personally think the same applies to the distribution chain. If we sort of require good quality distribution practices, it comes at a cost. So that basically, if you do that well, it squeezes out the small boys. And that's probably what you have to do and you have to expect there. So you have to recognize that quality comes at a cost. And the last thing I would like to say is that I think what the committee proposes is we want to promote good drugs rather than fight bad ones. So you promote good drugs by good companies dealt properly in a good distribution chain. That's what you want people to buy, and that will hopefully squeeze out the bad ones.
I just want to make one very brief comment before we go on, because we don't want to spend too much time with any one question. But cost has been an issue now, and of course, the committee's absolutely right that it would cost to invest in good quality drugs, but the payback for a government and a society is double, triple, much more in terms of reduced hospital costs, more productivity, better medicines, less antimicrobial resistant medicines. And so looking at this from an investment point of view, it's actually a very good investment.
We'll take our next question, please.
Thank you. Susan Finston, I'm president of Finston Consulting, and I've been working in this space, I guess now close to 15 years after starting with the Department of State and serving overseas in the Foreign Service, primarily in developing countries, and living in the Philippines and traveling quite a bit in MENA markets, Middle East, North Africa, and in India. So I think it is very important to focus on how you promote availability of good medicines. But when we talk about corrupt systems and organized crime, I think it's also important to be realistic and see how do we encourage good governance around the registration of drugs so that at least those drugs that are registered are GMP products. Because if people are buying a registered drug, they should have an assurance that if it comes with the endorsement of the government, that it is a good drug. And right now in many developing countries, that's not the case. In my own work in a practical sense, I've seen in Egypt and Jordan and India at the local and central government level, when you have e-government solutions for registration processes that are online and accessible to the public, automatically that increased transparency, they call it the disinfecting effect of sunlight on the drug registration process. And I've seen that in my own experience in these markets, that you have a great reduction of the registration of products that are not GMP when everyone can see online what the process is, what the steps are, and there are then therefore lower incentives or higher risks for people who are trying to get things into registration systems or formularies that don't meet GMP. I think there is a huge capacity building problem with how do we expect these regulatory authorities to be able to do a good job, but those who are trying to do a good job, I think, will benefit from the capacity building. Those that are seeking rents in the system, and that's a huge problem in developing countries that I think has to be acknowledged. A great way to get around that, again, not to shame and blame, but simply to put in systems that make it harder, and therefore they're taking a higher risk, and therefore if they're concerned about their position, they'll follow the process that's in place. And those e-government solutions, I think, have a track record. I'm wondering, obviously from these bullets you didn't say everything, but I'm wondering if the report is also addressing those kinds of points.
Did you want me to handle that? Okay, I can do it, but I'll defer to Margaret first, and then I'll wait.
Thank you. It's true when it comes to the challenges that the developing countries are facing in terms of ensuring that products circulating in the market are of good quality. And of course, as you mentioned, registration is just one of the items that has actually been a problem that many manufacturers have actually been complaining in terms of having the countries with different requirements and also not having the capacity to actually do the proper assessment. But of course, in the end, that has affected invariably the quality and safety of medicines that are circulating in the market. And so in view of that, I think you notice in the report, one of the recommendations is to see that governments do support regulatory agencies to actually build their capacity. And also another recommendation is to really try and see how governments and international agencies can promote harmonization initiatives. And the idea is that once you are able to really promote harmonized standards, for example, for registration of medicines, that in itself invariably helps in trying to, first of all, ensure that there is common understanding of the requirement, but also the issue of transparency is another aspect that is being embedded in some of these harmonization initiatives. And I think I'll be very specific here to say, for example, in Africa already there is the so-called African Medicines Regulatory Harmonization Initiative. And one of the key elements that is advocating is, first of all, streamline the requirements for registration of medicines across the continent using the regional economic communities. But secondly, also to ensure that there is a robust system for ensuring that there is the regulatory agency is able to track even the applications to the point that there is transparency in the system. But also there's a huge component for building regulatory capacity, because most of the countries, especially in developing countries, they don't have capability to do that. On one hand, you have situations where they don't have adequate legislation for a start. You know, the laws are not adequate to support the regulation of medicine. And secondly, you have the human resource capacity, you have financial capacity issues, you have infrastructure issues. So yes, it's true that there are these challenges, but what we are recommending here is to say, what can the various players do in order to assist developing countries to also be able to address this problem? And I think the report is very clear in terms of what should be done at international level, at the government level, and various stakeholders that are involved in this.
Yeah, I mean, everything you said I totally agree with, Margaret. And the good governance, of course, is very important to every aspect of global health, not just this one. Good governance as a general point, such as accountability, civil society engagement, transparency, and the like, was not part of our statement of task. But nonetheless, it is important. Of course it is. The South African Constitutional Court fairly recently made a decision saying that it was constitutionally required under the right to health and a Pan-African treaty. So it is clearly important. In Recommendation 7.1 of the committee's report, we talk about what I consider to be really some of the hallmarks of good governance, which is consultation with major stakeholders, including empowering civil society, being inclusive, transparent in trying to deal with this problem. And so governance is all part of that, and it's clear that we need to have a well-governed, well-regulated system with the capacity to do what's needed to deter, prevent, and ensure safety and quality of medications.
Thank you.
Okay.
Hi, everyone. Phil Cotticelli. I'm a media strategist, and I wanted to say thank you for a great report. We were, the people I work with, very happy to see the issue of substandard drugs tied to increasing drug resistance in the report. and it's something that I focus on and have been working on for several years. And also, you know, there was a study last week by Dr. Roger Bate at the American Enterprise Institute specifically on tuberculosis drug quality and, you know, trying to raise the issue of the relationship between drug quality and drug resistance, the acceleration of TB drug resistance. It's something, obviously, that's an increasing concern in America. So it was very good to see it in the report. And I was just wondering if, you know, if members of the panel could talk specifically about, you know, the IOM's position or, you know, where the science is on that relationship and how you might use this issue going forward to raise, you know, to raise the profile of the need to address substandard drug quality, not only for a disease like TB that's knocking on America's door again, but also, you know, across the broad spectrum of disease that, you know, that need the issue to be addressed.
Yeah, well, antimicrobial resistance, yes, Hans.
Yeah, briefly, and I think Margaret may want to say something. Well, the most published results, studies on substandard and falsified medicines in developing countries, actually many of them focus on malaria and artemisinin problems in Eastern Asia, where of course bad quality products or low dosages or zero content have really contributed to resistance, and that's a global threat because most of the malaria resistance has always started in that area, and that's exactly where it is now starting again, and really also well made worse because of unscrupulous sales of drugs that don't contain any artesunate, or just a little bit, so that your superficial handheld quality test will say, oh yes, there's artesunate in it, and it's 1/10 of the quantity that you need, and that's the very thing you don't want to happen. So that one is very well documented. I think a further study on it only makes the case that we have to be so careful. Making the case for tuberculosis is equally a global issue, and especially because these two diseases have the same well problem or solution, that you need multi-drug combinations. So then you really want to, they're prone to resistance anyway, so you really want all the patients to get 2 or 3, sometimes 4 medicines at the same time. If you then start playing around with the content, then that's exactly the strategy that doesn't work any longer. So thank you for it further makes the case clear that something has to be done.
Great. It'll be good to know, too, if the IOM is, you know, going to pick up on this relationship more, if it's, you know, just, if it's maybe too specific for your specific advocacy points, because
it's one of the key primary healthcare or public health reasons to worry very much about falsified medicine.
The report says a lot about that.
Sure. Okay, great. Thanks.
I'm Joel Bremen. Is this working? Okay. Previously of National Institutes of Health, interested mainly in tropical infectious diseases, and I'd like to congratulate the panel on all their recommendations, particularly 7, which suggest reasonably strongly, I guess, soft law for developing a code of practice that should be then taken into the countries where then they adapt it. Now, a member of the panel just said we should have a long-range solution here, and I'd like some elaboration on the political climate is not conducive to a treaty or covenant or convention that many, if not all countries, would agree upon, so that there would be some harmonization of agreement for addressing this not just problem, but in areas where I work, in the tropical areas, poor drug quality is murder. Not a crime necessarily as we have with a Gucci bag or a CD-ROM or DVD, but this is murder when you have an acutely ill child. And the penalties vary across the board from country to country. So we have conventions about tobacco, for trafficking of children and women, and in particular for counterfeit money, and on and on. These take a long time, but if we want a long-range solution, we have to at least begin at some time. So I'd like a little more elaboration how this was discounted. The second thing is what gets measured gets done, and the World Bank and others are now reconsidering the Millennium Development Goals, and Goal 4, 5, and 6 address the tropical diseases and other things, and it would be good to consider putting high-quality drug attainment in this mix of recommendations. And I don't know if the board has considered that type of recommendation, but I'd like some comment on those things, particularly from Dr. Natombo Segunda from a developing nation. As was mentioned previously, these drugs off the shelf for malaria are falsified in a third or more of instances where antimalarials are the top-selling drug in Southeast Asia and Sub-Saharan Africa.
Yes, I can elaborate on the code of practice, but I think Margaret and then Hans perhaps, and then I'll sum up. Does that seem like a good strategy?
I think just want to agree in the proposition that you're putting forward that this recommendation on code of practice, I think, is one of the very critical element in terms of really countering the problem of falsified and substandard drugs. And of course, you did mention about whether the committee considered the need for having a treaty, and I think this is a subject that Hans will be in a better position to explain. But in as far as I'm concerned, I think the reason why we had put up this recommendation was, of course, in recognition of the challenges that most of the developing countries are facing in terms of really not having standardized good regulatory practice. Much as, for example, you have situations where the World Health Organization has actually put some guidelines in terms of what the regulatory agencies should actually be doing in terms of securing, the quality and safety of products in the market. But most of the countries are not able to actually do that. And that's the reason why you find, most of the drugs that are circulating in the market are of poor quality. And therefore, the way to go around it through the code of practice, we thought, could be a starting point, because the process for coming up with a treaty, I think it is something that can be done in the long term, and I think Hans will be in a better position to explain that. But in as far as this recommendation is concerned, we think for a start, if the code is put in place with some clear guidelines as to what the regulators should be adhering to in terms of safety surveillance, in terms of quality control, in terms of market control, and all the core regulatory functions. For a start, I think it will really help in terms of ensuring that we have good, effective regulation of medicines in developing countries. So, Hans, maybe you can explain more in terms of the treatment and other aspects.
Well, I was at WHO, director of the Essential Medicines Department, when this whole discussion started in 2005 and 2006, especially at the International Drug Regulatory Agencies conferences, the IGDRA, every 2 years. And member states around that time were many of them were saying, well, we need a convention, and they were also like in the tobacco convention. But then when WHO was trying to go a little further into it, it became less clear. And also at that time, I think the topic was very much there was a lot of confusion about the words. Was it now a trade issue? Was it an intellectual property issue? And let me describe the time as countries and governments were confused, and it was not really clear, and it was difficult to make itself understood. Conclusion at that time was that there was, in the end, no consensus, not enough global consensus to move towards a treaty. And I know that at that time, the Director General of WHO, she was saying, WHO is not the one to start a treaty. If member states want to do it, I'm happy to do it, but I'm not going to initiate. So she was basically waiting for a majority of member states, and the normal way would be in the Assembly, to say we want a treaty, and then start working on it. And in the meantime, I think, now let's try to think, now what would you like to achieve? And I think we want to achieve things, again, in 3 stages. First, you want to discuss between all the actors and the countries, and you want to agree on standards and on nomenclature and things like that. So standardization and guidelines is one thing. The long run may be a treaty, which then by nature would be binding. But that may be, it may come in the end, but as a Commission here, we said, okay, we're not going to sit and wait for that. There's simply too much confusion and not enough consensus. But a looser, soft law, which brings together all the good practices, which is a guidance for interested governments, is probably as far as we can go. If then countries want to go and move to a treaty, that's not excluded. But this is probably more realistic and very much a technical goal. And again, it's a sort of like, to quote one of your presidents, it's a coalition of the willing. It is the countries that want to go and be serious about it can go for the voluntary code. And that's probably a more realistic option for the time being, politically. That's my judgment, but I mean, the more people will be able to say something about that.
Well, I thought that Margaret and Hans really nailed it. I think they were exactly right. We oughtn't to underestimate the importance of a global code of practice. Global codes of practice can do a lot of things that treaties can, but without scaring states off with binding obligations. They can set norms, agree on common standards, they develop the consensus process, and they can also have monitoring and feedback mechanisms to measure the problem, which is critically important for longer-term accountability. And the International Code of Practice on migration of health workers has not been a perfect success, but neither is the Framework Convention on Tobacco Control. But it has been it was a signal step forward, and this would be a signal step forward. And I think it would be wonderful for WHO to do it because it would establish their leadership, it would engage stakeholders and member states, and also I think I particularly want to stress the importance of our asking WHA to partner with UNODC and the World Customs Organization so that we make clear that this is a public health problem, a law enforcement problem, and a customs problem.
Harry, there was also the question about measurement.
Well, I meant to do with the measurement about the code of practice, because the codes of practice actually can agree on measurements. And I think that was, in fact, I've just finished a book on global health law, and in it, I talk about even these soft laws adopt many of the kind of measurements, monitoring, accountability of the longer term. But Hans, did you want to answer?
Just very briefly, in response to the question, I think the report makes a real gallant effort in collecting the information that's there. But all of it is I wouldn't say ad hoc, but there are different instances, different reports, different figures, which you cannot just add up to a global figure. Nobody will try that. But it's a good list of the reported and also a bit maybe less widely reported instances and figures. So I would like to recommend that. And I'd like to say that because the reporting was, the problem has always been this matter of definition, because if countries and organizations define things differently, they measure it differently, and you can't add it up any longer. And I think the report makes a very, let me say, again, very pragmatic solution. It's sort of roughly distinguished between the substandard, the falsified, and the trademark counterfeit issue, and then say, don't worry about the wording, but this is roughly what we mean. And WHO is doing the same thing. I know I can't speak for WHO, but I know they're doing that by now simply recording the case and describe the facts. They don't attach a name to it, they just describe the facts, and later you can classify them as you want. But in the meantime, I think global recording systems are being built up.
Yeah. John, why don't you have the final comment on this question so we can move on to the next question?
Just a quick comment on the code of practice, because you said something that I think is very important and very interesting. You said people die from some of these falsified medicines, and it's murder, but it's not murder. And when we talk about a code of practice, I think one of the things that's important is for governments around the world to recognize the significance of falsified medicines, to recognize that people do die from taking bad medicines. They die either quickly because of toxic ingredients, or they die slowly because of the lack of therapeutic value. But I think that governments need to look at criminalizing the counterfeiting of medicines, and I can tell you factually that in many countries, counterfeiting the packaging that medicine comes in carries a more serious and heavier criminal consequence than counterfeiting or falsifying the actual medicine. So I think that's one of the issues that needs to be addressed.
Yes, and the report spends a good deal of time, thanks to John, on the law enforcement part.
Let me just comment. The major challenges are sampling and the technologies to use for identifying the drugs. There's just a whole panoply of technologies, many of them back in a central laboratory, so the results don't come promptly. For instance, Cambodia has 27,000 mini or pharmacies out in the field. So to control all those is a huge challenge. How do you sample? What do you sample? What do you sample with? So those are the issues in terms of having a code that can be adapted locally.
Right, and we have separate recommendations in the report on technology.
I'm Paul Jensen. I'm a global health strategist. I'm a co-author on that, the TB drug quality paper that was published last week with Roger Bate. I'm just wondering, what do you see as the role of the U.S. Congress and other parliaments, say, in the next year? What can they be doing to help make progress toward achieving the recommendations that you have in the report?
Well, I mean, in the report, one of the things that the IOM requires of its committees is that when we make a report, we have to direct it at someone. And so in the report, there are a number of recommendations that are directed at Congress or at national governments. In terms of Congress, suggesting to authorize the FDA for a track and trace system would be one important area, but there'd be others. For national governments, we suggested improving regulatory capacity. But if you go through even just the executive summary and look at the recommendations, you will see to whom we've addressed the recommendations. Some are to Congress, some are to the FDA, some are for private investment, some to the World Health Organization and the like. So we have a nice balanced mix of actors that we would like to incorporate into this because we think it's a multi-stakeholder solution.
Sorry, I looked at the executive summary. It was an indirect way of asking if you could comment on that the audience who may not have seen them.
Right. Well, I thought I did. I mean, which recommendation would you like us to amplify? The track and trace, which is a congressional recommendation, boards of pharmacy, registration. Are there any particular ones you'd like us to discuss? No? Okay.
Hi, good morning. José Luis Castro from the Pan American Health Organization, which is the regional office of the World Health Organization for the Americas. Thank you for inviting us, and thank you for sharing the report. Just in brief, I would like to know, you mentioned in a way, but what is the committee thinking about the next steps in the way forward, operative steps, I mean, to share this report and to just these recommendations that you are proposing to discuss them, and mainly what are the next steps in the national level and towards the World Health Assembly that you mentioned and the international mechanism of member states?
In terms of dissemination and trying to talk to various stakeholders, I wonder if Pat or Gillian would be best placed to answer that question, because it's a question addressed to the IOM. It was basically what will the IOM do in terms of dissemination, reaching out to agencies, Congress, the World Health Organization, and others to try to inform stakeholders in terms of implementation of the report?
Well, we've already provided briefings on the Hill to interested parties from both the Senate side and the House side, and they were very, very interested and engaged in the issues recommended by the report, and particularly it was very clear that they have been thinking a lot about track and trace and how to technically achieve those kinds of things. We'll be over the coming months working with the FDA to determine the best ways of disseminating the report, not only domestically and globally, and are planning a variety of events that may be targeted at particular audiences that would benefit from a discussion. And we hope to involve some of the committee members in those kinds of discussions. We also are planning some additional publications. JAMA, the Journal of the American Medical Association, for example, has invited us to produce a short commentary about the report in that setting. If any of you here want to suggest particular settings, professional association meetings, for example, or presentations to our counterparts at the World Health Organization or PAHO, we're very open to that. So we not only are developing our own dissemination plan, but we're open to having the opportunity to present in forums that you might identify.
I might also add to that list, we've briefed the FDA commissioner and her senior staff. They were very much engaged in the discussion. And before the report was written, we did a number of site visits and meeting with stakeholders. And we'll report back to those with our results. We have a little glossy brochure. We might do that in other languages, like Portuguese or Mandarin, and then would be another way to disseminate it. And we've had discussions at WHO with Interpol and others. Leave it up to you.
Well, this has been quite a detailed and lively discussion, and I'm pleased that so many aspects of the report's conclusions and recommendations were able to get a fuller discussion. We have just released this report, and obviously we know a few of you have had a chance to read through and digest several hundred pages worth of the report, but there's a lot of great detail in it, so we hope that you will take the opportunity to peruse it in depth. I want to thank all the members of the committee who were able to join us today. As you can tell, this committee really tapped a lot of international expertise on these issues and brought them together for this study. They did so on a voluntary basis, sharing their time and insights, so we really appreciate everything they did to advance thinking and discussion on how to tackle this global problem. With that, we will bring this briefing to a close. And again, please visit www.iom.edu/fake drugs for more details, information, and material about the study. Thank you.